Greetings, and thank you for joining me as we discuss the Alabama Integrated Care Network. This is an internet-based version of a presentation that we completed in 9 different cities throughout the state of Alabama on behalf of the Alabama Medicaid Agency in the month of June. The goals of the presentation are as follows. We wish to explain the current services and program support for those in or at risk of going into nursing homes. Describe what the Integrated Care Network program is intended to provide, describe the parts of the Integrated Care Network system, and explain how they will work together with or change the current system of services and programs, describe the Integrated Care Network implementation steps and timeframes. The true goal of the forum is to obtain your feedback to make sure that integrated care systems design the wishes, needs, and goals of the people meant to serve. Whereas a Q&A will not be available during this presentation, we will offer you an email address to which you can submit comments or questions. So let's discuss the current system. The legislation for the Integrated Care Network programs allowing Alabama Medicaid to move forward with creating the program was passed unanimously by the Alabama legislature in May of 2015. We're currently in the planning and engagement phase, and so in that phase, while we're making decisions, we're conducting a great deal of research, and so that research includes Centers for Medicare and Medicaid requirements, which are often evolving, and so it's important that we understand them. Understanding other state best practices, there are a variety of other states that have embarked on processes and projects like what we're attempting here with the integrated care networks. And so it's important to pull from those examples both their successes and areas of opportunity where we can avoid pitfalls. We're also engaging stakeholders, which includes consumers of services, their caregivers, direct service providers, advocacy organizations, etc., in an effort to get as much feedback as possible so that it can drive design. We'll be entering into the 2017 phase with procurement and further engagement. The legislation calls for a public procurement, which means that interested bidders will be able to apply to become an integrated care network. Thus, we'll be taking all of that valuable information that we obtained in 2016, coupled with agency decisions around program design and operation, and releasing those in a procurement such that interested bidders will know what's expected of them and expected of an integrated care network. Once those bids are received, they'll be comprehensively reviewed, at which time a decision will be made around what entities will make the best integrated care networks for the state. And we'll be engaging consumers throughout that process along with other interested parties so that we can be transparent as an agency as to the extent that's possible. In 2018, we'll be entering the readiness and go live phase. And so once this phase starts, we will have selected appropriate bidders, and we will be moving forward with screening those bidders and getting them ready so that when we launch in October of 2018, which is our goal at this time, we will be fully ready and prepared to serve consumers and make sure that we have a seamless process for that. So when we talk about the care and services included in the Integrated Care Network, what do we mean? So really, we envision 2 key components. Number 1, your healthcare services, which are often more easily understood by people because regardless of your age or disability, you've likely already interacted with some of these providers. So healthcare includes entities like your hospitals, doctor visits, home health if you need it, pharmacy, and behavioral health as required. But in the integrated care networks, we also seek to include what are called long-term care services. And so in long-term care, we really have 2 major buckets. Number 1, nursing homes. Nursing homes have been around for quite some time. They're well represented throughout the state. Many of us have had loved ones that have been in or are in nursing homes, and some of us may have even spent time in nursing homes as a resident ourselves. And so we will be including nursing homes in our design, and they will be included as a key service. In addition to that, we will have what are called home and community-based services, which are newer but are often prevalent throughout the state. Currently, there's approximately 10,000 consumers across Alabama served by home and community-based services in a number of different Medicaid waiver programs, the largest being the Elderly and Disabled Waiver Program, which serves roughly 9,200 individuals annually. And so those home and community-based services are an alternative to nursing home insofar as they provide services to help people remain as independent and well cared for as possible, but rather than them moving out of their home, these services are offered in the home. Last but not least, we also are looking at the PACE program. For those who are not familiar with PACE, PACE stands for the Program of All-Inclusive Care for the Elderly. There is one PACE site in the state of Alabama, and it is located in Mobile, Alabama. PACE is not a program that CMS envisions expanding to a statewide level. It's often tied to an individual site, such as a day program or a residential site. And so PACE programs are really designed to be local. However, they offer some great insight and opportunity to understand where blending services and coordinating care is valuable. And the goal of enveloping all of these into integrated care networks is to improve quality, access, and sustainability. So how are services currently paid for? You'll hear the term fee-for-service, and in the fee-for-service model, the medical care and services you need are paid for after the service is provided. This is a pretty basic model. Anybody who's conducted business in a restaurant or a grocery store would understand this model. Essentially, you seek a service, you receive the service, and you pay for that service. While it makes a lot of sense for us as day-to-day consumers, there are challenges for a public health care program like Medicaid as it pertains to this model. And in large, the biggest challenge is that when you're paying for a service, you want high quality in that service. And so tying quality to payment and making sure that it incentivizes outcomes is really key. And so what are the challenges when we don't do that? Number one, when quality is not a part of how people are paid, members have a higher risk of emergency room and hospital visits. And really the reason for this is because when nobody's paying attention to quality and or quality doesn't influence how you're paid, people may be less attentive to the needs of their patients or clients such that people fall through the cracks. And so we really seek to avoid all preventable incidents of this as possible. Not to say that providers don't currently pay attention to this, but there's certainly opportunity that if you tie funding to wanting to avoid these preventable episodes of care, that likely those preventable episodes will subside. Number two, the system is confusing, requires multiple medical providers, which candidly is a challenge for our consumers and their caregivers. And so Alabama Medicaid recognizes, along with the long-term care continuum, that it's really important to make the system as seamless as possible. And when you don't incentivize providers working together, it's easy for them to continue to work in their own silos or buckets, which can make it difficult for consumers who have to work with a number of different types of providers, and it can lead to waste. We all acknowledge that there is sometimes duplication of service where people are prescribing more prescriptions than are necessary, or might be having duplicative testing or assessing people and asking them all of the same questions, which we seek to avoid, both to be more efficient but also because it's just better for our members. Number three, it's hard for the state to budget for Medicaid and predict how expenses might change in future years. Healthcare costs are changing quite a bit, and we also have to cope with the fact that both at the state level and nationally, the population is growing older, and as people age, they require long-term care services, which constrains government budgets. And so in this particular year where we've really had to be attentive to how the system is impacted by funding and how to be cost efficient, it's very important to look at long-term care and where we can really be prudent with the budget and make sure that we're getting the best bang for our buck in the expenses that we incur as an agency. And last but not least, there's just not a lot of reason for medical providers to work together as a team, particularly as it pertains to finding the best setting for patients. So what does that mean overarchingly? what it means is that right now what we're paying for is quantity, not quality, and we certainly want to move away from that. So what is the current long-term care system in Alabama look like? So you'll look at this diagram and see our little blue stick figure who is in the midst of this maze of different types of services, all of which are related to each other but often work in separate segments and may not be well connected. So you'll see that this diagram includes common elements like your doctor, hospitals, family care, behavioral health care, self-care, long-term care, community-based care, including other programs that people might be receiving, and the emergency room as it's needed. And so you see all these zigzag of lines throughout this particular slide to demonstrate that the consumer and their caregiver really have to navigate a maze of different providers and communication in order to be successful in obtaining the care and services that they need. And that, of course, poses significant challenges. In addition, Medicaid up in the corner is paying for a lot of these services, which of course poses challenges as an agency in trying to align these different parts of the system in order to provide the best possible care for Medicaid members. So what are states doing to resolve this zigzag maze? They're transitioning to coordinated care models. And in a coordinated care model, patient care activities are organized between 2 or more participants, which includes the patient, involved in that patient's care to facilitate the appropriate delivery of healthcare services. So what do we seek for the system to look like as an agency? You'll see that this particular slide depicts what we hope to move forward to as a model for the integrated care network. And so you'll see some key features of this diagram include that the member is at the center. And so we want to keep that in mind. You know, when we look at competing priorities in healthcare, really what drives whether we're successful or unsuccessful in the services and care that we deliver is whether or not the member is well cared for and successful and in the best possible health and quality of life as possible. So we really want to keep that as the foremost driver of the decisions that we make about the Integrated Care Network program. In addition, you'll see that the member is flanked by 2 different parties that are really very important to care. Number 1 is family and friends. The Alabama Medicaid agency is fully well aware of the amount of unpaid caregiving that helps keep our members healthy, with quality of life and well cared for. And so it's impossible to envision a system that doesn't include those family and friends in a way that helps augment what we're trying to do and support our members to the best of their ability. Care coordinator is also really a key component of the program, and so a lot of folks are familiar with social workers or case managers if they're on a waiver program. The care coordinator is designed to be a bit more comprehensive than the current roles that exist in the system today. Care coordinators would be interacting with members on a regular basis and helping them to navigate that outer ring of care that you see in the blue, which includes all the different segments of long-term health care so that members can move through that system as fluidly as possible, help that member to communicate effectively with all of the different providers of service that they have to interact with to receive their care, and also help all of those different care providers to stay in the loop on members and communicate with each other. The care coordinator is really a gatekeeper in a lot of respects for how to get to services and really make the most of services, help educate the member, help the member to manage things like self-care and quality of life measures. So there's a lot of opportunity to use a care coordinator to really drive the system in a way that we can be much more thorough than we can be in the current state. And as you move to the left of the diagram, you'll see that there are 2 intended outcomes of moving to this model. Number 1, the quality of care is expected to increase when you have all of the different parts of the system working together as a team. We anticipate that better decisions will be made, better care plans implemented and followed through on, etc., so that members have just a better experience and much better outcomes as far as health and quality of life. And you'll see that the cost arrow shows that the cost should go down. Now, I'll preface that we don't anticipate that costs will actually go down or that we will necessarily reduce costs by implementing the integrated care network. You'll hear us use the term that we're bending the cost curve. So we have two elements that work against us as it pertains to controlling costs. And I mentioned these earlier. Number one, healthcare is simply getting more expensive as time goes by. And number two, there are more and more individuals who require this level of care, so we're serving an ever-increasing volume of people. And so in order to try to keep costs in line and maintain what's reasonable and feasible, we have to really control what costs can be prevented. So that goes back to things that are wasteful, like unnecessary hospitalizations and emergency room trips, duplication of service, and just poor planning and execution. So let's talk about the Integrated Care Network program. Let's first review the legislation at a very high level. The legislation calls for one or more integrated care networks. The integrated care networks are providers who assume responsibility for providing care to older and disabled adults. Integrated care networks will be coordinating both nursing home and home and community-based care, and members will not be able to receive care from both a regional care organization or the RCOs and the integrated care networks. So who will be eligible to participate in an integrated care network? Number one, we anticipate that all current Alabama Medicaid members residing in a nursing home will be included in the integrated care network. Number two, all Alabama Medicaid members currently receiving home and community-based services under any of the following waivers are to be included in the integrated care network. And those waivers include the elderly and disabled waiver, the State of Alabama Independent Living Waiver or SAIL waiver, the Technology Assisted Waiver or TA waiver, the HIV/AIDS waiver, and the Alabama Community Transition Waiver or ACT waiver. And we want to make note that as people enter the system, you'll hear an eligibility term used called being nursing home eligible. And we want to acknowledge that that term can induce fear in consumers and caregivers who may not seek to move into a nursing home right away or may wish to hold off on that and remain in the community. Being nursing home eligible does not mean that you will be required to reside in a nursing home. It simply means that you meet certain functional and healthcare needs that would make you appropriate for a nursing home should you choose to live in one. But we want to make very clear that with the integrated care network, we really want to maintain consumer choice and autonomy and allow the members to decide what's going to be best and really offer the most quality of life for them, their caregivers, and the system that surrounds them. So what are the goals of shifting to coordinated long-term care through the ICN program? At a very high level, the goals include increasing the quality of care, improving access to and appropriateness of care, and this really goes to two different layers of long-term care services. Number one, home community-based services, and we've really had a lot of opportunity to talk with members throughout the state who have helped us to understand that home and community-based care can be challenging to find. Not all services are available to the extent that they need to be in particularly rural areas of the state. And there's a lot of opportunity to expand access to a number of different types of services based on people's needs and wishes. But we also want to look at nursing home care and access to nursing home care, because we've also learned from consumers that one really important feature of the ICN and one real challenge at times with nursing home care is finding a nursing home that is close enough to your family and friends that they can continue to visit you and participate in your care. So we want to be in a position where those who are truly appropriate for nursing home care are in nursing homes and occupying the beds in nursing homes, so that when people might have changes in their condition and move into that level of care, they're able to access a bed nearby their family and friends, acknowledging that that's very important to both quality of care and quality of life. And last but not least, we want to control the costs of care. And that's something that I reviewed earlier, but we really want to be as prudent with how we pay for care and really reduce preventable episodes of care wherever possible so that we're as efficient and successful as we can be as a system. So that brings us back to the right side of the diagram of what we envision the ICN system to look like and offer. And so at the Medicaid level, we really have 4 tenets that we want to see as a payer, which is that the right care is being offered in the right place at the right time for the right cost. It's a tall act to follow, and it's certainly not easy to obtain, but we really believe by working together with stakeholders and the healthcare network, we can achieve this very lofty goal. So how will a coordinated program work? For those who are not familiar with capitation, it's a bit similar to if you pay your utility bill utilizing a budget plan. So in a budget plan, the average of your utilization for, let's say, your electric is averaged out over a year, and that amount is then broken out on a monthly basis so that rather than paying based on how much electric you use each month, which can go up or down, you have a consistent payment that is your budget, and you pay it every month, and it accounts for both the months where you might have a high electric bill and then the months where you might have a lower electric bill. So capitation is very similar. And so how that works is that a prediction is made of how much it should cost to provide a consumer's care. And so this prediction is not something that's willy-nilly or pulled from the sky. There's a lot of analysis that's done by actuaries that use Medicaid claims information and a lot of very high-level predictive modeling that helps us to understand what prediction is appropriate for different members. And that prediction is then formed into an amount called the per member per month, or PMPM amount, that is paid on a monthly basis to the integrated care network, who then must take that amount and deliver care using those funds through doctors and other providers in a network that they've established. And the integrated care network is responsible for, or at risk for, costs should the care cost more than the per member per month predicted amount that was paid to them. So let's talk about some examples of what this might look like in real world. Meet Alice and Roy, and also Ben. Alice is 62 years old and lives alone in a senior apartment in Huntsville. Alice suffers from diabetes, heart disease, and gout, and receives home and community-based services. Roy is 77 years old, lives in a nursing home in Mobile, suffers from Alzheimer's disease and a history of stroke, which requires him to reside in the nursing home. And then we also have Ben, and Ben is 34 years old, lives at home with his wife in Birmingham, and suffers from paraplegia, or paralysis from the waist down, and epilepsy, or seizure disorder. He receives home and community-based services, and we included Ben because we see more and more diversity in the types of consumers that we provide. Ben may still be working. He certainly still has a wife and a functional life. We want to understand that the needs of people change all the time, and so as we redesign the long-term care system, we have to really acknowledge the diversity in the people that we serve and how that diversity might lend itself to how we have to design the program. So let's look at a month of care delivery for Alice, Roy, and Ben. And I want to make note as we look at this slide that the figures that are depicted on the slide are not meant in any way to represent actual costs for services. They're simply numbers that were pulled together to really make the point of what capitation means in the day-to-day operating of providing health care in an integrated care network type program. So you'll see that Alice's monthly budget, or her predicted PMPM, is $2,500. And within that budget, the integrated care network would have planned for the following: her doctor's visit, her HCBS, or home and community-based care, her heart doctor or cardiologist, her medication, and transportation. And so what happens in this particular month for Alice is that nobody realizes that Alice's new medication makes her dizzy, and so she falls and goes to the hospital. That hospitalization leads to $3,000 of additional expense, and so what you will see is, compared to the monthly budget paid to the integrated care network, she was over budget for the costs that were incurred to care for Alice in the month. And so Alice won't be responsible for those payments, and the Integrated Care Network cannot come back to the Alabama Medicaid agency to ask to make up the difference. So what will happen is they become responsible to bear that additional $2,000 of expense, which incentivizes an integrated care network to avoid incidents like Alice's, which likely could have been prevented if she was properly screened after receiving her new medication. Now we look at Roy, and Roy's monthly budget is higher than Alice. His level of care is different than Alice's, so we want to make note that not everybody's predicted amount will be the same. But if you look at Roy's services, based on what we can predict Roy to need, Roy falls within his budget for things like doctor's care, nursing homes, physical therapy, medication, and a new wheelchair. And what happens in the month for Roy is that Roy's nurse identifies that he has an infection at an early stage. And for those of us who have ever experienced something that seems minor like a urinary tract infection, they can really, if untreated, evolve into serious health crisis. And so Roy gets an antibiotic early, which takes care of the infection, and he avoids going to the hospital. And that antibiotic is $50. And so when we look at that added cost, Roy remains within his predicted per member per month amount, which is a positive. It basically represents that when Roy had an issue come up, which they will and they do, the nurse was responsive and she acted early in a way that was both good for Roy, because none of our members seek to go to the hospital, and it was good for the system because it was efficient and it was a low-cost level of care. And then last but not least, we come to Ben. And Ben's monthly budget is $3,500, and you will see that Ben's predicted figures include doctor's visits, HCBS, adaptive equipment, medication, and transportation. And so what happens in the month for Ben is that Ben's care coordinator learns he has a pressure sore. And this is something that's very common for folks who use wheelchairs because they have a lot of friction and may have a lack of blood flow to certain parts of their body. And so because Ben's care coordinator learns about this, likely just through talking to Ben and staying aware of what's going on with Ben, home health is able to start early and treat the sore early and often and effectively. And so that additional expense keeps Ben under budget, which again is a positive both for Ben, the Medicaid program, and also for healthcare providers in the ICN. So what's important about a coordinated system? The member is the primary focus of the system. Each member has a care coordinator. The member receives most of his or her health care from a primary care doctor. So that primary care doctor, or your family physician or general practitioner, whatever you call your doctor, will really be a central point of information and referral, in addition to a care coordinator, to really make some of the medical decisions that are required of a doctor. And so we want to see members going to the doctor as opposed to receiving their care in the emergency room or going to the hospital, which is certainly higher cost and often can be more stressful and difficult for members. And last but not least, all members of the care team will be required to work together to really meet the needs of members and develop care plans that are holistic and take all of the members' needs into account, such that people, again, have good quality of life and great patient outcomes, which is what we want to see. So let's talk about feedback, timeline, and next steps. So we have just come off of a very comprehensive stakeholder engagement plan where we were in 9 different areas of the state. And so we were appreciative for the many people who came out to those meetings, and again are thankful for you joining us to look at this presentation on the web, and certainly encourage you to provide your feedback at the conclusion of this presentation, as folks were able to do who attended our 9 meetings. And so you'll see on the list all of the different regions of the state that we were in. So we really attempted to cover all the different parts of the state and had a diverse number of types of stakeholders come to these meetings. So it was a great exercise for us. And so we're right now in the months of July and August compiling all of that really valuable input and responding to the literally hundreds of questions that we received so that we can get information out to the public in a prompt way that's really accurate and helps people to understand what changes might be coming and what improvements are expected. And so once we have compiled that information and developed a concept paper that we can release to the public to really spell out what we want the Integrated Care Network to look like, we'll be conducting our next round of stakeholder meetings. And at this time, we anticipate that to start likely in the middle of September or thereafter. Other ways that you can have input as a consumer or a direct service provider or advocate is through our consumer survey. And so we will be releasing a web-based survey in the month of August, and so there will be notice sent out when that survey is prepared and ready for you in the public to take. And we really request that you do and that you spread that survey far and wide. There are 3 tracks to it, one for consumers and caregivers, one for direct service providers, and one for advocacy organizations and or community members who just may have a vested interest in the Integrated Care Network program. We really want people to take the survey that's appropriate for them. There are targeted questions in those surveys that will really help us to get a lot of valuable information around what the general public seeks to see as we move through this planning process and prepare to make changes to the system that are intended to be positive changes. And so again, that will come out in August and will be available for a month for people to take. And again, we received over 200 questions during our 9 stakeholder meetings, and so we'll be releasing a frequently asked questions document that provides formal responses to all of those different questions and concerns that were raised in the public meetings so that we can get back to folks and provide accurate information and updates as they're available. And I do want to note that for those Alabama Medicaid members who may not have access to or are unfamiliar with using a computer, we certainly will be making resources available through the Department of Senior Services and the local area agencies on aging to assist individuals who seek to take the consumer survey to be able to have an outlet to do that without using a computer. So what our next steps for us as a timeline goes. So right now we are in the summer of 2016 where we are conducting stakeholder input and also in the process of identifying a Quality Assurance Council, and that Quality Assurance Council will play a key role in developing all of the quality metrics that an integrated care network will have to meet in order to demonstrate that they are fulfilling the expectations that Medicaid has set forth for them. We are also in the process of drafting a concept paper which really provides the nuts and bolts of what we envision the integrated care network to look like, and once that is released in the fall, we will be soliciting feedback from stakeholders in that second set of town hall and work group meetings that we intend to have throughout the state. In the winter of 2017, we will take all of that input that we receive in the fall and incorporating that into the concept paper simply to finalize it and essentially nail it down, incorporating the feedback that we've gotten, and that will drive our drafting of a waiver request that we will submit to the Centers for Medicare and Medicaid in order to get their approval on how we intend to move forward with the Integrated Care Network program. And so we'll be in the spring soliciting feedback on that waiver request and then submitting the waiver. In the fall of 2017, we intend to release the request for proposals to interested bidders who seek to become an integrated care network, and once those bidders are vetted and selected from the fall of 2017 to the targeted go live of fall of 2018, we'll be conducting member outreach, so letting consumers and caregivers know about the ICN program, what changes to anticipate and how to enroll. We will be engaging in readiness with the integrated care networks, which allows us to make sure that ICNs that are selected are ready to be successful and have all of the tools and requirements in place in order to launch as seamlessly and successfully as possible. And we'll be conducting enrollment so that we have members enrolled and essentially ready to start receiving services when we go live. So some next steps. Number one, please feel free to send questions in. You can send questions at any time to the following email, icninfo@medicaid.alabama.gov. Those will be received by the Alabama Medicaid Agency as they come in and will be circulated through the agency to the appropriate parties so that we can draft formal responses and make sure that we're providing solid answers to the questions and comments that come in to the agency. So please, if you have anything pressing, don't hesitate to forward that on to us for consideration. There is no foolish question. They've all been tremendously helpful, and so we want to encourage people to submit their feedback. And last but not least, please take the survey. We will be posting internet surveys on the agency website. Notice will circulate through a lot of the different chains that we use to get word out around the first round of stakeholder meetings. And so area agencies on aging, Alabama AARP, and other organizations will be sharing that information throughout the state. And when you receive it, feel free to send it on to colleagues, family, friends, neighbors, other interested parties that may benefit from being able to provide that really valuable input. And we want to also make note that assistance will be available through the area agencies on aging to assist those members, as I mentioned before, who may not have computer or internet access. And so as we conclude this presentation, I want to thank you for your attention and your interest in the Integrated Care Network program. Certainly continue to stay engaged and understand that we really value at the Alabama Medicaid Agency your input and feedback, and certainly wish you a good rest of your day and look forward to speaking to you with further updates as they become available. Thank you.